and good to meet all of you. So today's session is on medical ethics. So I think, shall we start, Sridevi? And
Yes,
I'm
we can.
sure
Yes.
as we are talking, you're going to be having many questions. You're welcome to put it on the chat box. Sridevi is around and we'll take the questions and discussions later. So, I mean, or in between, if you want to stop and say that's also fine, but put it in the chat box so that then we'll cover as many questions as possible. Okay. Can I share screen, Sridevi?
Yes, you can, please.
So I've chosen to call this as ethical decision making because this is what we do all the time. So let's think of this as using the principles of medical ethics. How are we going to decide with every single patient whom we come across? So when we talk about medical ethics, first, how do we define medical ethics? We talk about it as a critical evaluation of the assumptions that underlie medical decisions. So every medical decision that we take comes through a whole set of, multiple thoughts that go in our mind, multiple challenges that go in our mind. And so what is it and how is it that we make these decisions? So when we talk about levels of inquiry into ethics, there's something called we describe. So in a society, what happens, what we believe is right. And then you can evaluate this as per the norms and you can say this is how it should be done and that is how you have to stand in a queue here, this is how you have to go, this is the process, this is the protocol. When we analyze, that means we think, is this good, is this correct, will this do more benefit, will this cause more harm? So that is what is analytical thinking. So when we talk of medical ethics, we have to analyze and we have to think with a grid in our mind. So at the end of this session, I'm sure many of you may be doing it already. So for them, it is reinforcing it. And for those of us who are not yet doing it, let us start by thinking that by the end of this session, when we have a decision to make, when we have a decision to take, are we using the grid that would help us make that decision? So in medical ethics, one of the core things is what are the values that we deal with in a doctor-patient relationship. So because this is a very, very specific relationship, a doctor-patient relationship. The core of this relationship is built on trust. So some very, very important ethical points are what we call as truth telling, what we call as consent, which is an expression of trust. There is also something that we call as informed consent and what we call as implied consent. So would any of you like to put it in the chat box? What is informed consent and what is implied consent? So suppose I'm going to give a tablet of morphine. I prescribe morphine to my patient. What kind of consent do I have to take? What do you think that would be? Could any of you put it in the chat box? Or you can just unmute and answer. That should be fine too. So what kind of consent do you think it is? Because
I think we are getting mixed replies. Some of them are implied, some of them are informed consent.
okay, so
Both
that's good.
responses.
That you all have given me a mixed answer. So please remember that giving a tablet of morphine to a patient after you've decided that the patient has pain is implied consent. We do not need to take an informed consent to give a tablet of morphine to somebody because you are doing it. It's like any other medication that you give. So for every medication, we do not take that. So there is an element of implied consent. But suppose I am going to do a procedure. Suppose I'm going to do a surgery. I'm going to do any kind of procedure. That is when we inform the patient and take an informed consent. So morphine is not different from other medications that we give. The consent is implied. So and truth telling. So what we say in medicine, truth telling, consent is very, very important because that's what builds trust. If you lie to your patient once, they are not going to trust you again. The second important value is what we call as respect for life. So we are all very happy to care for our patients when they come to us right at the beginning, right? We are very, very happy to do the investigations, tell them multiple studies, and this is what your chances are, and all of it. But what happens to us suddenly when the patient starts deteriorating? What happens when you feel that I do not have medicines or I do not have anything to be able to treat the disease? Does the suffering stop? We all know that the suffering doesn't stop. And what we are doing by telling that patient, don't come back again, you don't need to come to hospital, or you can go home, is we are abandoning that patient. That is the time when they need us the most. How would we feel if somebody, when we went at a time when we need the doctor the most, tells us, oh, you don't need to come back because I have no treatment for you? So I told you this in my previous session, I repeat it now. At the end of this session, please learn never to tell your patients there is nothing that I can do for you. There's always something, because our goal is to alleviate suffering. As doctors, we did not come here to treat disease, but we came here to comfort and to stay with our patients till they live. Confidentiality, that is again being very respectful, because it doesn't make sense if we are going to announce, oh, I have so and so person who's come to me as my patient, discussing patients using their names in social circles or in other places. That is breach of trust. Privacy, I think right at the beginning of the session you saw in the instructions, there were that wherever names have been taken, consent has been taken. And otherwise, please do not use photographs, do not use names without their consent. That is respect for privacy. And in today's world, one photograph can just get viral, and it really should not be done without taking the patient's consent. So respecting confidentiality, privacy, and privacy starts even with simple examination. So when we examine our patients, we need to put a screen, or we need to keep one relative and keep the rest of them out, because I understand that many of us work in government hospitals, crowded OPDs. We don't have screens, we don't have doors, we don't have curtains, we don't have so many things. But still, try to keep that element of privacy instead of just walking in. And even when you walk into your patient's room, one knock can help. So preserving life and life experiences. So preserving quality of life, understanding that treatment is not just about curing disease. We'll come to that a little later. Another value is when we respect boundaries, because this is a consensual understanding that we have. Remember, it's a privilege. There is no other profession in which you can touch another human being the way a doctor can touch a patient. So that is a privilege. We have to think about it, because it's something that we do day in and day out. But if you sit and reflect, which other profession will you be able to touch another human being the way you do? So it is a privilege. You need to respect that. And acceptance of value and diversity, because what you feel may not be what the person feels. And upholding dignity. So there are a lot of cultural contexts in which we see patients, different places in which we see. In our country, what I practice in Maharashtra may not be true of what we practice in Andhra Pradesh. What happens in Bombay may not be true of what happens in a village. So we need to understand that there are boundaries. We need to learn that. And the most important thing is providing holistic care. So comfort, with all the inconsistencies we have, we can still comfort the patient, because there are going to be shifts in goals. We need to accept that there is diversity in values, and preserving personhood. This is the most important thing in palliative care, is preserving personhood. So if we have an idea, if we keep all these values in mind, and then move on as a healthcare provider, so we need the knowledge to apply these ethical principles, we need the attitude, and we need skills. So unless I know how to communicate with my patient, unless we know how to prognosticate, unless we know how to deal with symptom control, we are not going to be able to do it. Now, we also need to have the knowledge to apply ethical principles, which is what we are going to study today, and attitude. All the values form the core of that attitude. So knowledge, skills, and attitude as a healthcare provider is what, once we put all this together, that is how ethical decision making happens. So when we talk about ethical principles, we can have an agreement in principle, but again, do we all have the same principles? That's something we need to mull about. So when we talk about the fundamental principles in medical practice, the four fundamental principles are what we call as autonomy, beneficence, non-maleficence, and justice. So each of this we will be taking one by one, but can somebody put in the chat box what autonomy means to any of you? We know it's self-determination. So what does it mean? So what do you think is autonomy? Is there, so what do you think is autonomy?
Individuality.
My own choice, individuality, patient's right to decide. I am independent to take my decision. Patient has the right to decide for decision. Patient has the right to choose, able to make decisions on their own. Excellent. So how do you think a patient will choose or have a right to choose? Between medical decision making and autonomy, what should be there? Can any of you put that in? So yes, I completely agree that I'm the doctor. I give my patient the right to choose. But what is most important? Proper understanding of management of protocol and correct information. That is the core of autonomy. So that is why it's very important. It's easy to say I have the right to choose. But if the patient has not been informed properly, then that right to choose has no meaning at all. So each individual is a master of himself. Nobody else, not even the kin or the doctor, has more right. I understand that. But what happens in our country is different from what happens abroad. Abroad, I would not even talk, if I was practicing outside, I would not even talk to a patient's relative without the patient's consent. But out here, patient comes with his family, and in many situations, the patient is actually made to wait out, and you're supposed to talk to the relatives. So collective autonomy is a part of our culture. There is a lot of debate in that, which is true. In our center, we always believe in talking to the patient and the relatives together. And we can ask the patient, which relative do you want inside? Whom do you want inside? But remember, if we are practicing abroad, you need the patient's consent to talk to the relative. So there again, your confidentiality and privacy matters, because you might have a very inquisitive relative who comes and talks to you one day and says, oh, you remember, you see this patient, this is the file number. Can you tell me what happened to him? Be very careful, because you will need the patient's permission to talk to that relative if you've not seen him with the patient in the past. So, but what is even more important is, suppose I give you this case scenario that Mrs. A has a curable cancer for which she needs radiation therapy. Very common case scenario we see. But then she comes and tells you, oh, you know what? I'm very scared of radiation. I don't want radiation. I've had somebody who's died because of radiation and all of that. I'm not taking the treatment. So do you think that is autonomy? So what do you think is our role as healthcare providers? So do you think that we say, yes, autonomy, Mrs. A does not want to take treatment, and if patient understood, counseling, yes. So that is why you will have provide information, absolutely. So first thing is make her understand about the cure. Very, very good. So what do we do here? Our first approach would probably be, I would ask her, what is it that you know about radiation? And what are your fears about radiation? Which is when she can say, oh, you know what, it's current, somebody died, I don't want to take all this. So that is when we start with informing her. If I'm going to sit there and say, oh, don't you know that radiation is going to, cure your disease, and why don't you take it? She might just walk out of my OPD. So I might have to spend time sitting with her, asking her and finding out what she means by not taking radiation, and then weigh what we call as the risk and the benefit, which is what we do most of the time, don't we? So what we do here is tell her, do you understand that by taking radiation, you can live? But by not taking radiation, what do you think is going to happen? So we have to use the ask, tell, ask approach, which we have in communication, and get her to understand that the risk of not taking radiation is not living. And the benefit of taking radiation would be her life ahead. So unless you inform, unless you tell her, or about what are the risks, what are the benefits, the choices she makes may be uninformed. So that is why the most important thing in autonomy is whether it's an informed decision. Is she benefiting by taking this decision? Is there harm caused by this decision? And what is my duty as a healthcare provider? So, my duty as a healthcare provider is to provide her with the risk and the benefit and then get her to decide. So, making an informed decision is weighing the autonomy and beneficence, which is our second principle, and then taking a decision. So, that is why we call it informed decision making. So, autonomy is not just unilateral, it is understanding and then taking the decision. So that is why we call it a partnership in care. So always remember that the patient has come to you and the family and the patient know the patient best. You are sitting on the other side. You know medical treatment the best. So medicine is your strength. The patient information and family knowing the patient is their strength. So when we come to a decision, it has to be shared. So it is a partnership. It is not paternalistic anymore. That was in the olden times when the doctors just looked and said, this is how I'm going to treat you, and the patient obeyed. But today, we realize that medicine is not, it is not just a partnership. It's a very strong partnership between the patient and the doctor. It is shared autonomy, and both of them are experts in this. So that is why we have what we call as medical decision making, where we have the Johnson's 4-box model. So this is something I would really, really like each one of you to understand, because it's a very useful way and a very helpful way in which you can make ethical decisions. So next time you have a problem, think of it this way. What are the medical indications for treatment? So which medical indications mean what is the prognosis of this patient? How do I prognosticate him? What are the treatment options that I have? What is the benefit of this treatment? What is the burden of this treatment? That is what medical science is telling you. So that is your knowledge. You know that. Next, you move to what the family would like. What are the values of this patient? How old is this patient? Now, suppose you had a choice in giving palliative chemotherapy, and you had a choice in giving weekly or 3-weekly therapy. Now, we understand that this is palliative therapy. Maybe the difference in survival would be a few months. But think and tell this to the patient and ask them if they will be able to come every week. If they live near your hospital, they may like to come every week. But if they live really far away, is it worth subjecting them to this weekly journey? Because then she's going to almost live in the hospital. So these are what we mean by what is the patient's values, what are their wishes and what are their preferences, and most importantly, decision-making capacity. So decision-making capacity, one must understand that you can, if suppose you have restricted capacity in making a decision, you need to have a surrogate. If it is a child, you need to have the parent has a decision maker. So this is what comes from the family side. The medicine is in your head. The family preferences are in front of you, which will be told to you only if you ask. If you're going to just announce your decision, you will never know what they wanted or what is in their mind or what is it that they prioritize. The next is what we call as quality of life. What are the trade-offs this patient is going to have? What is the appropriateness of the therapy that I'm giving? What is the patient's expectation, hopes, and fears? So it is not just medical statistics that determine the line of treatment, it is also the quality of life. So as a physician, it is my responsibility. These are two parts which are my responsibility: medical indications and appropriateness and quality of life. What kind of quality of life am I giving this patient and what is the trade-off for that is an important question. And then comes the contextual factors. So what do we mean by contextual factors? Does this patient have an insurance? Are there legal implications? Is there any conflict? What about the resources? Now, this patient is a daily wage laborer and he is on a loan. Am I going to prescribe or monoclonal, am I going to prescribe immunotherapy for that patient when the difference in survival is 16 and 18 months? Am I going to do that? Because he is in no way to even take a loan or do anything. Or if I have the resources, how am I going to use them judiciously? What are the religious connotations? So there are so many contextual factors which are different for every patient. So whenever we sit in front of a patient, the medical knowledge is in your head. What the family wants is something you need to elicit. And in your head, you need to start thinking, what is the quality of life that I'm going to give this patient? Is it worth calling them every week? So you have to address that to them. Or shall I prefer a 3-weekly regime, which will be easier on the patient? And then the contextual factors. Can they afford this? What are the implications? So this is how one needs to decide. So in ethical decision making, is this beneficial? Risk versus benefit, very important. Is this accessible? Very, very important. Feasibility, affordability, and accessibility. I can't tell someone that, oh, you know something, maybe if you get this drug, your patient would be better, very mindlessly. Especially, we see that a lot of that happening in palliative therapies or even in immunotherapies. Patients are told, this is your option, option 2, option 3. And the patient goes into psychological distress, thinking that if I had the money, I could have procured this drug and maybe I could have lived. They still don't know that living meant a few months difference. And suppose you succumb to the toxicity, the few months that you had would also be gone. So half truths are often told. So that is what we need to understand and ensure that we don't do. What does the patient want? Is the autonomy informed? Are they aware of the options, the details, and the consequences? And most importantly, what are the goals of care? Unless we know what are the goals of care and prognostication, it is hard to decide ethically. So there are some special concerns, like whenever there's cognitive impairment, when there is depression, when they are children, then we need to identify a surrogate because the patient may pass their rights to them to take the right decision. So we need to assess capacity. Now, suppose you have this patient. She was the same patient who came to you in the beginning. You, as an oncologist, gave her chemotherapy and she continued the treatment. And after 6 months, you did her scans and you realized that the disease is progressing because she was admitted for toxicity. And you saw now that she has been admitted, she has developed toxicity. And more importantly, her scan is showing progressive disease. So any point in giving her more treatment is not going to help. So the patient turns around and says that you were the one who told me that chemotherapy would benefit me when I started therapy. Now, when my disease is increasing, you are telling me you're going to stop the treatment. So can somebody tell me, put it in the chat box, as to how you're going to answer this question? Because you were the same doctor who told them all the benefits of chemotherapy when they came to you 6 months ago. She was taking it. Now you are doing the scans, you're telling her that the disease is increasing and you're telling her to stop treatment. Now think of this from the patient's perspective, because they don't understand medicine. You have medical knowledge. The patient is asking you this question. So how are you going to address this? What would you like to say? Anyone you can type it, you can unmute. Make them understand that some chemotherapy do not work for all patients. Now, I would feel very cheated if you told me that. I would say, you should have told me this then. I took this treatment believing that therapy is work. Beautiful. Treatment is causing more harm than benefit. Very nice. Next, any other statements? There will always be a risk of adverse effects. That's a nice thing to say, but they will say, what if the disease has not responded as well as I thought it to be? There are always chances of failure. Explaining risk versus benefits prior is the solution. Very good. So there are 2 things that we learn. You are not responding to the current ongoing treatment. So I'd like to just pause on that statement. You are not responding, you're not responding to the treatment. So when someone tells you you are not responding to the treatment, what does it make you feel? What does it make you feel? Suppose you're taking treatment and you've gone hopelessness, yes, hopelessness, disappointed, true. And do you feel that this is my fault? Very vulnerable, true. And does it make you feel that somehow it's my fault? Yes or no? Sad? Yes. And responsible and guilty. So that's a nice things on the chat box that I could feel, that I could see. So that's very true. So I would like to just say that, try and avoid saying that you are not responding, because then the patient feels that I should have done something else, or this is my fault that I'm not responding. So already they're going through trauma. So a lot of these things were very, very good points that you all brought out. So usually in a situation like this, we would definitely say that, so there are two things we learn from this. At the beginning of therapy, when you start treatment, knowing that this is metastatic disease, we start with, right now giving you chemotherapy seems to be a good option because you will have more benefit, you have a good functional status, and then let us see how much this disease will be controlled. So you have already given a warning shot, you have told them, you have encouraged them, you're starting treatment. Now, when they ask you this question, you can definitely say that right now, in the situation that we are seeing and the scans that we have, giving you treatment may be more risky than benefit. So it might take away the good days that you have. So giving you the treatment might cause you more harm. So when we talk about medical ethics, that is what we call as benefit risk balance, which is balancing the beneficence and non-maleficence. Because as doctors, our first duty is non-maleficence, do no harm. So the essential chemotherapeutic drug in the early stage of the disease it will be totally unacceptable at end of life. But this is something we have to have a dialogue with the patient. We have to get them to understand that it is not that I'm stopping your treatment. The thing is that if I give you treatment, you will have some more hospitalizations, and maybe you may not come out of one of those hospitalizations. So the risk that I'm doing to you will be way more. So once you start explaining like that, then slowly the patients usually start understanding. So now suppose you have this 20-year-old boy who's come to you with osteosarcoma of the lower end of the femur. His tumor is really, really large. He has multiple lung metastases. Now his age is 20 years old, not an age where he likes to sit on a wheelchair or move around in a wheelchair. He is now telling you, amputate this limb. I don't want it anymore. The surgeon is very reluctant because he knows he's not even going to get fitness. This disease is going to flare up. Those lungs are already gone. We prognosticate poorly, but the boy is adamant. So these kind of situations are going to happen day in and day out. And so you are going to have conflicts. You are going to have the surgeon feeling one way. You are stuck in between the surgeon and the patient's family. Surgeon says, I won't operate. And then it falls on you as a palliative care physician to now sit and explain to the patient as to why the surgeon doesn't want to operate, why the boy has to live with a limb like this. So these are the challenges that we have every day. So demand for a specific medical therapy that doesn't have evidence, then what should the doctor do? How do you request the family to withhold? How do you respond to these demands? There is conflict of opinion in the family. There is conflict of opinion among healthcare providers. You know that the PS is declining, but suddenly someone has thought up of a new immunotherapy and they want to give it to the patient. How are you going to balance between, supporting your own colleague and also being an advocate for the patient? So these are conflicts, these are challenges which you're going to see every day. So like I told you, this session is going to leave you with a lot of questions. So this is because ethics is always about how am I going to get through this scenario, this question, and what is appropriate. So at that point, when you have so many conflicts, you need to sit down and say what is appropriate. What is the aim and benefit of the treatment? What are the burden and risks of this treatment? And then sit and balance it out. So if treatment does not have a realistic chance of achieving any of the aims, that is what we deem by, and we call it futile treatment. So futile care is what we call as medically inappropriate care. So when we are aggressively, like we always say, a simple blood test, a simple investigation, even there is ethical decision making. Because suppose I am not going to change my treatment with the result of that blood test, why am I subjecting my patient to do it? So always, when you order for an investigation, be it a scan, be it an X-ray, be it a blood test, you have to ask yourself the question, is my treatment plan going to change? If the answer is yes, go ahead with the investigation. But if your answer is no, then take a step back and reflect, why should I subject this patient to that investigation when I am not going to change my treatment, when I'm not going to add more therapy, when I am going to provide the care that I have been giving? So that is why you cannot justify by saying, but it's only a blood test. No, it is still an invasive investigation that you are doing. The results of that blood test, they are going to come back to you, and then you're going to say, oh, there's nothing I can do, will be even worse. So there is something called as futile care and medically inappropriate care. And there again, where communication is needed and integration between your colleagues is also needed. So the ICMR has this nice document. I would advise all of you to go through it, where it has defined terms used in limitation of treatment and providing palliative care. And that's why they've defined futile care. Today, we call it medically inappropriate care. So in a care plan, when you have good prognostication, when your care is proportionate, it is what you need. It is like salt in your food, not too much, not too less. And a good therapeutic relationship with your patient, that is what makes for a good care plan. Whereas the reverse of all of this is going to land up in trouble. So that's why in cancer care, we have this Choosing Wisely India document. We have 10 low harmful practices that should be avoided in cancer care. And if you see, the first point in that is, do not delay or avoid palliative care for a patient with metastatic cancer because they are pursuing disease-directed treatment. So we have the evidence, we have all of this. And ethically, this is how you make your decision. So if you have the evidence, and if you make your decision, so this is part of the medical knowledge that you're supposed to have. If you are an oncologist, knowing all about chemotherapy is great, but also knowing when to stop treatment is equally important. And that, I think, is more important than anything else. So suppose you have a 57-year-old man, he has advanced cancer lung, he's severely breathless, he has progressive disease in the lung, he has the insurance, he has all the means, there is no lack of funding, there is no lack of money, and he has now come to you and said, I want to be in the ICU for artificial ventilation. So again, you are going to be it's going to be very difficult for you to make this decision if you have to just decide it without having ever spoken to the patient in the past. So the decision making is always very situational also. If you're seeing this patient for the first time, decision making can be extraordinarily difficult. And if you have always seen this patient over a period of time, then explaining and communication becomes relatively easier. So now we come to what we call as withholding and withdrawing. So we know that there is a difference between withholding and withdrawing, how you make this decision, how you talk to patients, communication, all of that. But remember one thing, that there is no ethical difference between the two. So ethically, whether you withhold or you withdraw, there is no difference. But practically, it always helps to withhold treatment, because withdrawing can be very, very painful for patients and families. So when we call what we call as the fourth point of medical ethics, like we spoke about autonomy, we spoke about beneficence, we spoke about non-maleficence. Most important is what we call as distributive justice. What I am doing to one patient, will I be able to give all my patients, is something you need to ask yourself. So suppose this is your own person, you cannot just add something to the battery of tests. You need to tell yourself, what I'm able to do to one, am I going to be able to do to all? Suppose, are we allocating the resource of the ICU justly? These are questions we need to ask. In palliative care, I usually start with asking the family, are you in debt? Have you taken a loan? This is the first thing we need to find out, because if that family is in debt and taking a loan to give the treatment that you have recommended, you are doing harm to that family. And just because a patient can afford, if you are going to put them on all kinds of treatment, you're again doing harm to that family. And suppose you have an ICU bed, but the patient doesn't need it, and they have the resources, and you're dumping them in the ICU, again, you're doing harm. So that is why the grid should always be in your mind. These four principles should always play in whenever you make a decision. So today, for all ICUs, we have a nice ICMR DNAR guidelines. So all of this, withholding, withdrawing, they were huge challenges, and they are slowly getting better now, because you have documentation, you have ICMR support, you at least have some DNAR guidelines. So you have a nice flow chart there, which will help you in your decision making. So all of these are resources which I would advise you all to use on a daily basis. We have a new legal legislative. I'm sure Sridevi, they are going to have sessions on this, but I thought it's important to put it to say that guidelines exist when you have challenges in your mind, when you don't know what to do. You have a legal legislative, even for an advanced directive. And just very recently, as in last week, we have the new guidelines for intensive care admission and discharge. And what does it say? One of the criteria: the following critically ill patients should not be admitted in an ICU: when patients or next of kin informed refusal to be admitted in ICU, their autonomy, any disease with a treatment limitation plan. Why? Because you're going to do more harm than good, and you're not going to treat the disease. There is no point in letting them suffer. Anyone with a living will or advance directive against ICU care, that means they have made an informed decision. It is their autonomy. Terminally ill patients with a medical judgment of futility. So this is what we do 90% of our time. Metastatic disease, patient's admission, we discuss with the primary physician, we discuss with the family, we demonstrate medical futility, advanced medical disease, and then sign the DNAR form, because we know that we are not going to shift this patient to the ICU, because by doing that, we are going to cause more harm. Low priority criteria in case of pandemic or disaster situation where there is a resource limitation. Now, this can be very ethically challenging even for the physician, because then the onus rests on you. So this is what our newest guidelines say. So you can see a lot of ethics which has gone into these guidelines. So in your mind, especially as anesthetists, especially as trained doctors, and who are listening to palliative care for the first time, this question might cross your mind. By not doing what I have been trained and taught, is this euthanasia? Am I killing my patient? So I want you to be very clear about one thing, that euthanasia is active. It is deliberate. It means you're deliberately injecting something for the patient to die. So remember, it's a conscious decision taken with an intent to end a patient's life. So what is most important to understand is, what is your intent? Your intent is not to kill, it is to relieve suffering. Euthanasia is active. You're injecting something which the patient, with the intent that the patient is going to die. And this term called passive euthanasia, though it exists in our Supreme Court judgment, it exists in a lot of places. As a palliative care community, we are strongly protesting against that word, because that is what gives it a negative connotation. And withdrawing and withholding, don't think that because I have withdrawn ICU care, I have hastened death. I don't want any of you to think like that, because what we are doing, and that was a nice terminology which we used to call it AND, allow natural death. So by not intervening unnecessarily, you are just allowing the disease to run its natural course. And the person is going to live till the time that he or she has. And we understand that the treatment is not going to benefit the patient anymore. So we are respecting beneficence, we are respecting autonomy, we are respecting non-maleficence. And what we can do for that patient, we will be able to do for most of our patients. We are respecting justice. So this is something, and I'm sure you'll have more thoughts. We can discuss it, because There are just a couple more slides. I haven't kept my talk very long. This is another thing that might confuse you all, which is what we call as the rule of double effect. So this is a principle that distinguishes that what treatment you're giving is what you intend, but you can have an adverse effect, which though you foresee it, was not intended. So I'll give you a simple example, like when you're giving your patient chemotherapy and the patient has a terrible reaction after that, and it even causes the patient death. At that time, you're going to tell yourself, see, I gave chemotherapy because I thought it would benefit the patient. This was not intended. Though it has been documented, it is foreseeable. It can happen in the rarest of rare situations. But then this was not your intent when you gave chemotherapy. Okay. So why does the same principle not apply to palliative care? So whenever we give a combination of morphine, midazolam, alloperidol, we are doing that with an intention to reduce patient suffering. We are not doing all this to kill the patient, because that is something you need to understand. The patient is still arousable, the patient is more comfortable, the patient is way, way more comfortable than what he was when he came. At least let us provide comfort and relieve suffering. For that, we adjust the doses and we give him all of this. So I need you all to, these are difficult principles to understand. You will need to read a little more about it. You will need to practice it. Experience will teach you. But remember, it's the intent which is important. The intent is not to kill, it is to relieve suffering. And you have to train, you have to be, with a sound medical knowledge, you have to be doing all of this. The most important principle, ethical principle, as far as I'm concerned in palliative care, is non-abandonment. It's not in palliative care, in medical health care. I think if you tell your patient that I can't see you anymore, I have nothing more to offer you, you are technically abandoning that patient. And Dr. Brennan has a very nice article in which he says, when medical science does not have an answer to the patient who's coming to you at your door for suffering, and you're just silent, it means medicine has failed. So remember that there is always something that we can do for a patient who's suffering. We could be there. We are all co-travelers in that journey, but we could definitely be there. And one should never say nothing else can be done. And I also want you to reflect on this when we talk about ethical decision making. So George Bush, he was 91 years old and he died from vascular Parkinson's disease at his home in Houston, Texas, and 94 years old. And when he died, his last words was, I love you too. And for those who've definitely known about Sri Atal Bihari Vajpayee, he was 93. He had IST, he had stroke, he had dementia, and he suffered pneumonia, multi-organ failure. He was on ECMO support on the last day. So was this ethical decision making? This is something we need to. So this is exactly what I mean by justice is distributive justice. What we gave Vajpayee, can we do it to everyone? Was it what he wanted? Did we do more harm? Did we do more good? These are things we need to ponder. We may not have all the answers, but we need to think about it. And the same thing with Lata Mangeshkar, when she died in that ICU. Do we know what she wanted? Do we know what, or just because somebody is a celebrity, did we give her what the kind of end that we gave her? So slowly we should transform into a society which believes in ethical decision making, be it a celebrity or a prime minister or the man on the street. Very tough to do, but still, I think we can still work towards it. So now I am ready for questions, because I am sure there will be many. Sridevi, I would like it if you would like to add anything, please.
Hello. Hello.
Yes, please. I can
Yeah.
hear
Good
you.
evening, ma'am. Is it legal to give DNR consent in our country?
Yes, we do have the ICMR guidelines. So usually it's not a unilateral decision. So what we do is it has to be by a team of doctors, and whoever is the treating physician, in our center being an oncology center, the primary physician, the palliative care unit, the family. So we have a meeting, we decide and we document it. And we get the consent of the patient also. We talk to them and get the consent. So the ICMR has that entire guideline. So please go through it. And what I would advise is each hospital should have their policy. So AIMS has their end-of-life care policy. I'm sure all of this is going to be done, right, Sridevi? End-of-life care policies will be done.
It will be
That's why I
covered
did
and
not touch on it.
document will be shared also.
It's going to be done. So AIMS has, Manipal has, and ICMR guidelines are there. So hospitals should have an end-of-life care policy, and then according to the policy is what you will do.
There is one question, then what do we say? I think it was during your presentation on.
Okay.
So then what do we say to patients when there is no treatment options? I think when you are discussing futility, and that's when this question came.
What do we say when
There are no treatment options?
Okay. So instead of using that negative connotation and saying there are no treatment options, can we do it a little better? So in oncology, we usually start with, okay, this is your disease, but right now we do not have treatment for the disease per se, but we always have treatment for your symptoms. So we usually ask them, what is troubling you? The patient has never told me till now, the cancer of the larynx is troubling me. He has always told me the pain is troubling me. I have breathlessness. I have this. I cannot walk. So we say, let us address all the points that are troubling you, or all of these. And then another thing is be realistic. Don't say I am going to bring your pain score from 10 to 0 today. That's not going to happen. So we say that let me try by making you feel better. By all of this support is always going to be there. So usually they come to me downcast. They say that chemo doctor said there is no need to come. So then we start by saying that we are always there, and let us know what your problems are, and come on, let us start. And for all this, we are going to address. Here are the contact numbers. This is how we are going to follow up. This is the hospital is open for you, or we are going to do home care. So I would always like to tell them what we are going to do instead of focusing on what we are not going to do, because that's something they always already come to us with that information. Can symptom control in the patient with and be done at this stage? When we have seen in fact, we have seen patients' decision overtaken by relatives, friends, and having independent view. Yeah, that again is a very valid point when the family wants something and the patient wants something. So we need to give it time. Patients may say, don't take me to the hospital. I don't want this anymore. Family is pushing, especially, with patients on dialysis. You see a lot of that even in non-cancer. Nutrition, hydration, these are all areas where family will push on one side, the patient will not want. So in these times, what usually helps is a time window. So we say, okay, if this is what we want, can we do this on a trial basis for a day and see how the patient feels? And then so we give that 24 hours time, when instead of directly refusing what they want, we have that little intermittent path. So especially in matters of nutrition, hydration, that's what we do. We say, okay, you want us to give the patient fluids, you want us to give this, let us do this and try and see how he feels tomorrow. And then let us make our decision on that. So that gives us a little time for negotiation, because the family does it with love. They feel that giving him fluids is going to help him. But instead of directly telling him it's not going to help him, we demonstrate it, wait for a day, give them the chance to understand what is happening, because all the information, there must be an information overload and it may be very difficult. So we need that time. So communication is very important. Absolutely. You will understand that the core of everything in palliative care or in patient care actually is communication.
I can't see any other question in the chat.
Can I
Ma'am. Sure.
Ma'am, I go for home cares. So one patient, he had carcinoma of the urinary bladder. When we had gone to see him, he had a lot of pain, so he was advised morphine. And at that time, the patient gave a history of rat bite. So we asked him to get vaccinated. But the patient, they did not want to get vaccinated. And whenever we called them up, they were very, rude. They said that you are coming and giving us extra advice. It's not possible for us to take the patient. So they did not follow any of the advice. And after that, whenever we called them up, they kept blaming our home care team for all the problems that the patient was having. That the patient was much better before. After your medicines, the patient has deteriorated. And the home care team is now like they do not want to really address this patient or call him up. So should we call that abandonment? Or actually they are so the patients and the caregivers, they do not want to do the treatment that has been advised, but they keep on blaming us for whatever is happening with the patient.
So Manisha, how many patients has this happened with? I mean, you've done how many home cares and how many?
Oh, we do almost 20 to 30 per month.
Yeah.
But this has happened with this patient specially. This one I remember because it is going
So,
on.
So
Only
I
day
think in
before
every,
yesterday, we called them up.
So everywhere we are going to have these kind of outliers. And honestly, we had this situation, the similar situation. Last week, my team came back very disheartened because they went for home care and there was some man who walked in and who said, "What is the use of all of you all coming? For so long you all are coming. But nothing is happening to our patient. Why are you doing?" Very rude. And my staff were they were very disturbed, but they just held on. They came back, and after that they decided to call the son and spoke to him and said, "See, I thought we took your permission and came home, so what is it that was so the son said, "See, we have been managing our mother for 7 years, but this is a relative who has come now, and then he is acting smart, so I apologize on their behalf." And but in spite of that, we wrote in our notes that next time confirm who is at home and then go for that particular home care. So in situations like this, I think maybe it would be better to let it rest for a while and to pursue maybe telephonically or instead of going there directly, because I'm sure the team is not going to enjoy going for that home care visit. So we have to look at the team's perspective also. I am not going to say that you are abandoning this patient. You can put him on a telephonic call and tell them that we are always there. If you need to reach out for anything, we will be able to help you. I think that would be one solution, because if you are going to prioritize this one patient over everybody else and the staff have trouble, you are actually destroying the entire home care. So you're not doing justice to everyone. So if someone behaves like that with you, which happens to all of us, Manisha, I'm sure Sridevi will share this, her experience. Yeah. At some point, it happens to all of us. And one thing there is, please don't retaliate in anger, because it is the family's frustration that's coming out. That kya fayda hai, you come home also, but still my patient is the way that they are. So abhi ye sab karne mein kya hone wala hai? In their mind, it probably could be that. So don't retaliate in anger, but please take a step back, give that home care a break, be available for them over the telephone and inform them accordingly. That would be what I would say. Sridevi, please add.
Yeah, you said it perfectly. Just one more thing I would like to add is that if they choose to come back, many times they choose to come back, then make sure that you're not making any unnecessary comments. We have the temptation to say, "Oh, I've told you that time itself." Now, they may come back even in a worse situation than before. They might be in severe pain or symptoms. So it is very important to tell your team members not to be too judgmental when they are deciding. Most of the time, they would come back. If they have taken the freedom to yell at you when you go for home care, they know that this is a place where they can come back. So that's one thing that to hold back from blaming or unnecessary comments from the team. That's all.
Very true, Sridevi. Thanks for adding that.
Yeah, thank you, ma'am. Now, actually, what happened that when we told them that we are always there for you, but what they did was they called us. They said, "Can you provide an ambulance? Can you admit my patient somewhere?" Things which we are not able to do at the moment. So when we communicated that to them again, they got more angry. So this is how things are at present. So yeah, maybe, but I've
So
got
next
your
time
points.
when we say, let us know what we can do, so we have to come to
Okay,
see
so
you.
thank you,
Yeah,
ma'am.
that's true. Yeah, I think Dr. Suela, there's an entire session on that. I just touched these things, that's all, but you're going to have multiple sessions.
But if there is any pressing question, Dr. Suhaila, you can ask. But if you're asking about the whole concept, we will have discussion and session on that, and we'll be sharing the document. But if there is any specific question, you can definitely ask.
Yes, Dr. Das, psychosocial issues are always there. It is like onion peeling. You see the physical, but when you start peeling, that's when the psychosocial, the spiritual comes up. So it is there in uh, everything. Something has bothered them and they just took it out on you.
Dr. Sheila, you were trying to tell something before. You wanted to ask something?
Yeah, doctor. Good evening, ma'am. I wanted to ask when will this when the relatives don't want us to communicate with the patients about the disease. So can I ask questions relating to that, or that will be taken in another day? I mean.
Collusion will be dealt in
Yeah,
communication.
we have one
So
session
we're
on
going to have a full
communication.
session
Yeah,
on collusion.
Okay, then
yes,
I'll ask there, ma'am. No problem.
sure.
Thank
Don't
you.
forget to ask at that time. Keep
No,
your
no, I
question
have a
in
lot
your
of
mind.
patience. I want to ask this. I will definitely ask.
Sure.
Thank you.
We can move on to case presentation now, and then we'll take up discussion based on that. Sangeet?
Yes, ma'am.
Yes, Dr. Janani, you can start your presentation.
Hello. Yeah.
Yes.
Hi, ma'am. Good evening, everyone. I'm Dr. Janani. And I'm a senior resident in IC. Did my MD and
Dr. Janani, your voice is breaking.
yeah.
Unable
I'm
to
working in KMC HS Coimbatore.
Dr. Janani, your voice is breaking. We are unable to hear anything.
Next slide, please. Oh, yes, ma'am. I'll look at it. Hello. Am I clear now, ma'am?
Yes, but can you try talking?
1 minute, ma'am. 1 minute. Am I clear, ma'am, now?
You can try it presenting your
Hello.
slide.
Can you just try stopping your video and then trying?
Ma'am, am I clear now?
Can you just start presenting? I switched off your video.
Okay, ma'am. Yes, ma'am. Yes, ma'am. I'm presenting a case of a 75-year-old male patient with a diagnosis of urosepsis in shock, acute on chronic kidney disease on hemodialysis, Parkinsonism stage 4, systemic hypertension,
Dr.
diabetic,
Janani, I think your voice is
and an
not
old
clear.
CVA with a left-sided weakness and a cardiac disease history. Next slide. Yes, ma'am. Hello.
Yeah.
Ma'am, am I clear now?
No, your voice is breaking. It is not clear.
He had presenting complaints, he presented with complaints of fever with chills and rigor for past 1 week,
Dr.
cough with
Janani, I think
expectoration
your
for
voice
1 week,
is,
decreased food intake for 1 week, and decreased past.
Dr. Janani, your voice is not clear. We are unable to hear you. Either you can try changing the room where you are sitting.
1 minute, ma'am. Is my
Yeah,
voice
now
clear
it
now?
is better. Now it is better. You can speak now.
Yes, ma'am. He is a 75-year-old male patient with a background history, with the background of Parkinsonism, presented to us with a diagnosis of urosepsis in shock, acute on CKD, on hemodialysis, systemic hypertension, diabetic, and a whole severe history with left-sided weakness and a history of cardiac disease. He presented to us with complaints of fever with chills and rigor for past 1 week, cough with expectoration for past 1 week, decreased day-to-day activities for past 1 week, and decreased food intake. He also had a history of decreased urine output for the past 2 days and an altered sensorium for past 2 days. History of illness. He's an elderly gentleman with Parkinsonism stage 2 and with multiple other comorbidities who was catheterized for the past 1 week, for 1 month for the urinary incontinence. He, with the diagnosis of BPH. And he had paucity in left upper and lower limb for the past 6 months after the CVA attack. He had a stroke, and he was doing his day-to-day activities like eating, bathing, and walking with support till last week, and that is before fever. And once the fever has set in, he initially went to a local hospital where he was treated for on OPD basis and also as an inpatient for 3 days. And during his admission in the local hospital, they have found elevated renal parameters, and his sensorium started worsening slowly. So he was referred to a higher center. So in our emergency department, we received the patient with a GCS of E3, V2, and M5. He was drowsy but protecting his airway. And receiving heart rate was 120, BP was 70/40 mmHg, saturation of 96% in room air, and respiratory rate of 22. And he was resuscitated with fluids, and noradrenaline infusion was started to support the blood pressure. And he was shifted to ICU in view of worsening hemodynamics and need for intubation. So on receiving in ICU, patient's GCS was E2, V3, M5, protecting his airway. Heart rate was 99 beats per minute. BP of 110/70 with an noradrenaline support of 0.2 mics, and saturation was 99%. He was supported on NIV, non-invasive ventilation, and respiratory rate was around 28. On a examination, systemic examination, on auscultation, bilateral air entry was present, decreased on the lower basal zones. In CNS, we can see tremors right side more than left, and power was right upper limb 4/5, lower limb of 2/5, left upper limb 2/5, left lower limb 1/5. Deep tendon reflexes were sluggish. Babinski's was right extension, left withdrawal. So initial blood investigation showed hemoglobin of 8.3, serum potassium was 7.8 on receiving. After medical management, serum potassium was repeated after 1 hour. It was 7.3. ECG showed tall T waves in primary leads, and urea was 230, creatinine of 5.3. Liver function test was within normal limit. His urine routine showed plenty of plus cells with bacteria, and his ABG showed severe metabolic acidosis with bicarb of 8. CT brain showed old changes, and CT abdomen showed bilateral perinephric standing, fat standing, features suggestive of pyelonephritis with a mild hepatomegaly and bilateral pleural effusion. Initially, he was taken up for SLED dialysis for resistant hyperkalemia since his potassium levels were resistant to medical management. Central and art lines were secured in view of vasopressor support and worsening GCS. Pan cultures were sent. Airway support with NIV. And during the period of hemodialysis, there was furthermore hypotension, so supports were increased, and he was started on antibiotic piperacillin tazobactam 2.25 grams q6 daily as per his creatinine clearance, and his hemodynamics was continuously monitored. Neurologists and nephrologists were consulted, and attenders were counseled regarding his status of septic shock and worsening outcome. So his GCS on day 2 of ICU stay was E3, V2, M5 to M6. He was treated on alternate dialysis. Antibiotics were escalated based on the culture reports, and he was slowly weaned off NIV. He was maintaining saturation in room air. Enteral feeding was started, and he was not tolerating oral feeds. And the blood and urine cultures showed E. coli growth, so he was escalated to meropenem. His in view of drop in GCS, again CT brain, MRI brain was taken. Despite we have taken one CT brain on admission, so again that showed a chronic infarct and age-related changes. No acute conditions. So he has developed hypernatremia during the stay. Correction was given, and he also had a hemoglobin drop up to from 8.3 it was 6.69. Since he was going on alternate day dialysis and on ICU admission, so 1 unit of PRBC was transfused during dialysis. Outcome, he was in ICU for about 10 days. He was treated aggressively for septic shock, and his GCS improved to E4, V3, M6. His BP still drops during every dialysis. During dialysis, he needs a minimal vasopressor support, and his limb power did not improve much. He needs hemodialysis for lifetime. Parkinson's, as such, is life limiting disease, which has progressed from stage 2 to stage 4, wherein initially before this acute infection he was moving around with the support, but now he's bedridden, dependent on attenders. So psychosocial aspects of this patient: he was a retired government official with a supportive wife and a son who is a bank manager by occupation. And though he had multiple comorbidities on regular hospital follow-ups, he has a good family support, and they want to continue treatment at any cost. And till this acute infection, patient was communicating mostly non-verbally over the past 2-3 months, and he was mobilizing with support. And he was an authoritative and type A personality till now, and he used to visit nearby temple during his daily walks till last month. And he believes in charity, and he has expressed his will as live unharmed and have a peaceful death to his wife. And during his ICU stay, he was dull throughout, was not cooperating for the procedures. He showed anger towards his wife and son during the attendance visit. And his primary physician, who was treating him for Parkinson's, has conveyed to us that patient has never wanted any invasive treatments or hospitalization if his Parkinsonism worsens to stage 4. So patient conveys his pain through the facial expressions. He always has this grimace on his face, and he has wrote a written note on in ICU to a staff, like he just wants to disconnect all the wires, leave him to die in the hands of his wife. But when this was conveyed to the attenders during our counseling sessions, attenders wants to continue ICU treatment, dialysis, even intubation if as and when required. So his medications were injection meropenem 500 mg, Q8 on ecosprin AV, Syndopa plus for Parkinsonism, soda bicarb tablets, Rantac, syrup Duoflex, and physiotherapy and other supportive measures. See here, the main concern of the patient for this case is Parkinson's, which is a life-limiting disease, which has worsened his this quality of living, which was slowly progressing. Now, due to this acute infection, it has aggravated his quality of living from stage 2 to stage 4, wherein his day-to-day activities are dependent on attenders or wife. Then he also has a prolonged ICU stay, alternate day dialysis, multiple IV lines, bedridden, and he also has he lacks emotional pain. And here patients will to discontinue the treatment has overridden by attenders will. and considering the beneficence, since hyperkalemia, he has recurrent hyperkalemia, beneficence in this point of view, we are doing continuous dialysis, and again, dialysis is prolonging his life. The point of doctrine of double effect is being affected here. So summary, coming to the summary, 75-year-old male with the Parkinsonism stage 4 and other multiple comorbidities with septic shock and acute on chronic kidney disease on regular dialysis. So here my discussion points are: how can we respect the autonomy of the patient? In intensivist point of view, what is the role of beneficiaries? Am I doing it's no harm, so I have to go ahead with the treatment of septic shock and a dialysis, even though the autonomy of the patient is affected here. And what about the withdrawing and withholding of treatment for this patient? And again, this prolonged ICU stay and dialysis and invasive treatment from what is the beneficence here. And the primary physician says again the attended the patient did not want any invasive treatment when his Parkinsonism worsens, but this acute event has worsened the condition. So how to go about this?
Thank you. Thank you, Dr. Janani.
Thank you.
We'll wait for some chats to come up from participants. What do you think about Dr. Janani's patient? And we'll not, I mean, it's always overlapping when you take medical ethics about the advanced care planning and end of life care, but we'll focus more on the ethical dilemmas in this situation. Yes, Dr. Sheila, patient had clearly expressed his decision. So Dr. Janani's question is, can we actually respect the autonomy of the patient? And she's asking how much the beneficence role is playing out here in this situation.
Ma'am, I want to say that this treatment is not going to cure the patient. I mean, and every day he's in pain with the dialysis. If patient told that I don't want to be connected to the wires, we could have called the relatives and we could have explained to them that your husband is saying that the patient is expressing that he doesn't want to get connected to the wires.
Ma'am,
Yeah.
can I? Ma'am, patient attenders clearly wants to continue the treatment till the end, and they are okay with whatever may be the end, but they want to try till the end, but they want to save their dad from pain. This was the statement of the son, and they don't want to opt for uh, withdrawing or withholding treatment. But the patient has expressed he doesn't want any more treatment.
So the patient's expression, the what the patient had expressed, that was given conveyed to the relatives.
Yes, ma'am.
Okay.
There are a few other comments. It is poor prognosis, then we should go for DNR because patient's decision is very clear and already his dignity is compromised. So, or his decision making is compromised since he's not knowing what is happening. And Dr. Chaitra is suggesting that we should have conversation with the patient attenders about the unnecessary treatment, which will increase patient's pain. So these are a few comments in the chat. Vidya, would you like to respond to the?
This is very nicely presented. How are you feeling?
Ma'am, from my point of view, I think we should respect patient's autonomy and give him a respectful death. And we can treat his pain and even the breathing difficulty if he has overload status or something. But the invasive procedures, he's totally not willing. But considering the patient is a Parkinson's with a altered sensorium presentation, here the capacitance of the patient is also in a questionable state. So
I asked you how
we
you were
rely
feeling.
on.
Thanks so much. That is a lot of medical information that you gave me, which I needed. But can you also tell me how are you feeling when you're presenting this?
Mama, from my opinion, I would like to give a end of life care for this patient.
No, I don't want your opinion. I just want to
Uh,
know how this makes you feel as a doctor, as a person.
Ma'am, again, from my point of view, I feel as though I am doing harm to the patient if I stop the treatment. And on the other perspective, I think which is right and wrong. I'm confused here. How to go about it? That is my state of mind, ma'am.
What I'm trying to ask you is, do you think, or how are you feeling? If you were feeling good about this, you would have been happy. You may have never presented it here. But there is something which is troubling you, right? Whether you're doing right, whether you're doing wrong.
Yes, ma'am.
Yes or no? I wouldn't say right or wrong, but it's troubling you. So you have said over there, is this beneficence? But you are feeling that you're not doing the right thing, you're doing more harm to him, because look at the number of invasive procedures this man has gone through after saying that he doesn't want to go through any of that. So if I was a relative and of this patient, and if you told me that, I will withdraw, I will withhold, I will do this, I will do that, then the relative feels that they have so many options. But maybe you could try to tell me that, you know what, in view of all of this, let us look after him. We understand how much you love your husband or your father. So, how about if we try and shift him to the ward and try and put him on whatever he needs for comfort? Because let us see if he has bed sores, let us see if he has this, let us address all the symptoms and start on that note. Because, and one more thing as a doctor, I mean, Sri Devi, you can join me here, is that there is no need for you to offer to intubate this patient, because what does your mind say? Is intubating going to be a solution for this patient?
No, ma'am.
Then
Considering.
you don't need to offer it. So if it is futile care, it is not only the patient's relative. That is why I'd like you all to read the ICMR guidelines, that book which I put up. As a doctor, you need not you need not give them that option, because it is not an option that exists. For a patient like this, you may be telling them that I think after this dialysis, we are going to put him only on this medication, because this is what is quality of life. Because even one more needle is going to cause him to bleed or cause him more pain. So let us start by doing this. And if they say ICU, you say, but it's not an option for him, because he will probably die even during the process, and that is doing harm to my patient. So I understand this is very, very difficult coming from where you are, but you should know what is harm and what is right. And if you had asked me right in the beginning, when you started, when you spoke about all the procedures you were done, you could have gone even 2 steps back for your next patient and start there. Because I need you to answer this honestly. When you started treating this patient the way you started, did you believe that this patient was going to survive and come out of this whole thing?
Uh, Actually, no, ma'am. Considering the
Yeah. So
presentation, uh, if
you
that
presented
if
it so beautifully. You told us all the comorbidities. You said Parkinson's, so many of those things. This patient is never going to come out. So that was your prognostication. So you prognosticated, but at every step you're doing this for someone else. You have to use your medical science and your conversation right then. That is one thing. And this also emphasizes on the value of early palliative care, which means if there was someone who was already addressing the Parkinson's and talking to the family, which is what we do when in palliative care. We create these scenarios way in advance and tell them, if this happens, this would be our approach. So this is such a valuable case, and such a valuable case that you've presented in so many aspects. We can use it in so many different aspects of teaching, because it teaches us the value of therapeutic relationship, early palliative care, importance of symptom control, and not multiple lines and dialysis and correcting labs. What we are doing in patients like this is literally correcting labs.
Yes.
So we are correcting the reports, but we are not addressing the person. So these are areas where we might have to start early. And you need to also know that as a physician, your right is that you can make a choice on the treatment that you're going to give if it is not beneficial to the patient. So you have done so well. I really admire your fortitude in dealing with this patient, because I would have crumbled if the patient told me, I don't want this, pull out this wire, and the family looked at me and said, no, still go about it. I mean, honestly, very, very tough.
Thank you so much, ma'am.
Any other questions or comments from the participants? I totally agree that this is a very difficult situation, and Vidya asked the right question, that how are you feeling? It just drains you out. I mean, you can't, I may not be able to function after having these many discussions with the family and then with the patient, and then convincing my own colleagues, my own team members, and taking, we always want to take the right decision and not to be blamed by others, right? So that pressure is always there. So that's the right question in the
And one
beginning.
more thing, I'm sorry, Sridevi.
No, I finished. I just want.
The thing is, you can also involve colleagues, suppose Parkinson's, then a neuro. If suppose you sit together as a team like neuro, so and so, and give them the inputs that this is not going to be beneficial, but this is what we can do. So instead of saying, I'm going to put him in the ICU, I'm going to do this, you say that right now, putting him there can cause him more harm, but this is what we can do because this is what we foresee. And if you do it as a team, you have more support. Instead of just one person, if you can involve the neuro. So that's where shared decision making comes in. But I understand that those are difficult. I don't know the scenario you work in, whether it's a private setup or where, but
Yes, ma'am. In a excuse me, like in a private corporate setup with the tertiary care
then
and being in an ICU,
it is
telling
very
about the
tough.
palliative care or early palliation itself will be it will be totally a difficult situation, ma'am.
Yeah. And one more thing we usually do in PALCA, we also say that, when patients ask you, can you do this? So then a nice way to say is, if this patient was my father, I may not have done this. So which, in a difficult situation like this, which says that, okay, maybe this is not, if they wouldn't do it for their own, then there may be something seriously wrong in this. Dr. Malvika has raised her hand. Yeah, can involve the family physician. Very nice statement, which is a dying species today. I would love to see more family physicians. It would be so nice for the world.
Hello,
And
ma'am.
new information, Dr. Jyoti is telling certain hospital charge the patient for such team.
Sorry, ma'am, I couldn't get that.
Oh. Hello.
Yeah, I think Dr. Malvika, I think you raised your hand first. Malvika, then Manisha and Hital Kumar.
Yes, ma'am. Dr. Malvika here. Ma'am, at one end of the spectrum, we talk about the advanced treatment options like mechanical ventilation and ECMO, and now that we have stem cell therapy for Parkinson's and so on and so forth. And at the other end, we say we are allowing natural death and withhold and withdraw life support just because the patient is not happy with the lines. As an anesthetist and intensivist, I don't know like what is right and what is wrong in this point, ma'am.
Malvika, that was a very honest question that you asked me. But given all the interventions, it is also medical science and knowledge to understand where it would work. So suppose this was a healthy person with no comorbidities had come to you with urosepsis, I would justify the interventions. But now you're thinking of a person in his, I think he was in his 80s with multiple comorbidities, with Parkinson's, with urosepsis, and with I don't know how many other things that he had. And so it is always prognostication. Just because I have something, I'm going to use all of it is not medical science. Just like how I'm going to investigate the patient and then find out without an examination is also not medical science. So understanding that you have the resources, and just because we have it, it may be there in your city, in your center, but is it available everywhere? How important that resource is? How can we justify using something which has no benefit? Because that's why I asked Janani that question. What did you feel? Did you prognosticate and think that this patient is going to come out of this the way she described it? She just said no right up front.
No, my point is, ma'am, like if I
Who's your
don't try on,
yeah, sorry, yeah.
ma'am, if I don't try on this patient today, like how will I know will it be effective or not on the next patient, the same patient which comes tomorrow?
So knowledge, skills, attitude. You don't try everything on anyone. Knowing what to try on whom is medical science. So you don't try, like we see patients with cancer just because this is what was told to me by my very senior director. He said, just because the patient is young, don't think that you're going to do anything heroic. It's the worst thing, because when the cancer is so aggressive in a patient who's so young, I mean, that particular kind of cancer, this is where you need to stop treatment. You can't let emotion override the fact that I have to give treatment because this patient is young. This was what he had clearly taught us and demonstrated to us. So understanding what treatment to provide whom, prognostication is the key. And that is your entire medical decision making, quality of life and prognostication. There are beautiful examples. Go in and just you could read about it. It's about similarly on this lines is one patient with extensive burns who was treated, and he was an Air Force Marine and who came out completely crippled, went into depression, cursed his family for treating in spite of him saying that I do not want treatment. So that is where our quality of life, what are our goals and expectations? What is it that my treatment is going to provide? And just because I have something, doing it is not, that is what is choosing wisely. That's exactly what is choosing wisely. So
thank you so much.
It's ethics is always like this. It's difficult, not easy. And just because, I'm so happy you mentioned this and you spoke about it up front, because this is what goes on in many of our minds.
Yeah. Ma'am, I just want to share an experience of mine. Recently, I had gone to my parents' place because it was the marriage of my brother's son. And my father, he's 82 years old, suffering from hypertension, cardiac CAD, and COPD also. So that was for about last 10 years, he's been on medications. During our stay over there, just the day before the marriage, he had severe respiratory distress. He was admitted, and it turned out to be lobar pneumonia, for which he was admitted. And I requested the doctors to allow him to go to the wedding, but they said it was not possible. And I was like in a fix, because here I am a doctor as well as a daughter. I have to listen to my relatives. I have to listen to to the doctors also. So ultimately, we could not take him to the marriage. He was admitted for about 4 to 5 days. And after the marriage was over, I forced the doctors to release him. I said I would give him antibiotics at home. So I took him home. I gave him the antibiotics. But I realized that my father was very angry with all of us, because he had been planning to go to this grandson's marriage for about 6 months. And he said, I have not even seen the venue where the marriage was held. Everyone enjoyed, everyone attended, but I could not be there. I do not know what I have done. If it was right on my part, should I have taken him to the marriage and not got him treated during that acute episode? I really don't know. I know he's very angry with me also for doing that at that time, though he understands that the treatment was also essential. But I don't know. Could you just tell me? I still sometimes think and cry over it that I have.
Manisha, don't be so harsh on yourself. You did what a daughter and a doctor both would do, because you weighed the harm that would come if he did not take that injectable antibiotic, because given his age, if it had not gone on time, it may have, the implications could have been worse. So that would have been in your mind. Was that what was on your mind? Because I think that was a wise decision. Like how someone else has also written over here, he's written the same words, because this was someone who was walking around, moving around, doing everything, and this is an acute episode. At that age, if you had not addressed that acute episode, maybe things would have turned out worse. So I don't think that you should feel bad. Yes, the hurt that he couldn't attend the wedding would be there, but in today's times, maybe you could pacify him by showing him the video or the recording, or
Yeah, that we are doing regularly.
I'm sure you'll be doing that.
I mean, in fact, after he came back home, we had a small function at home where we asked him to wear the dress he had.
Oh, wonderful.
Yeah, he had made for the marriage ceremony, and we asked him that you wear this today, and we'll call the relatives and have a small function at home so that at least you get that festive feeling.
His photographs are in there with the rest. So
yeah,
I don't think you should be hard on yourself at all for this. That's my feeling, and I think most of them feel that way, whoever it is.
Thank you so much, ma'am.
Hetal Kumar.
Yeah. Good evening, ma'am. Actually, I'm an anesthesiologist, and we are doing CPR training for people, laymen, and nursing staff, and all since last 8 or 9 years. By teaching CPR, again, ethical dilemma comes that when a patient is saved, it is good, but sometimes patient has hypoxic damage and they become vegetative. So, what to do?
See, this is something we have also discussed at length at our center, because how many of the CPRs actually work? How many of them are done properly? And sometimes the patient could be terminally ill and you're doing CPR when he didn't want it and when it's not going to help him. So honestly, I don't have an answer to that, because on one side, I think you have to think of the number of people whom you would save in a crisis versus for how you go about it. Honestly, I don't have an answer, because this is a discussion we do have. And one of my consultants actually says, I want to get DNAR tattooed on my chest because I do not want this to happen to me. So we have discussed this quite a few times. We are training people, but we are not ever training them to see on whom they're doing the CPR. And so it's a huge subject that you've opened up. I don't think I have the right answer to it, Hetal Kumar, honestly.
Thank you.
Sridevi, you can pitch in.
Yes, same thing. The only thing I would think is that what was my intention when I was giving the CPR? That's the only part I can cling on to. Like my intention was right, or my intention was not to harm any patient. But still, it is a very, very debatable topic.
Yeah, because he's absolutely right, and many times it's done on somebody who's so. But the problem is, how do you make everybody understand at that point, and that too in a point of crisis? I mean, retrospective decisions are always 100%, but then what at that time? So
yeah, it is very different from the palliative care scenarios, right? Where we get months or weeks to talk about this and prepare ourselves as well as the family. When you are in a crisis situation, many of these principles.
Acute scenario, it's very difficult. Yeah, you've never seen the person before.
Thank you so much, all the participants and Dr. Vidya, for the wonderful discussion. I'm sure you are yet to go back home from hospital.
Yeah. And happy Sankranti and happy Pongal to all of you. And
thank you so much.
Okay.
Thank you, Dr. Vidya, for all the
Honestly, it's
wonderful
so
words.
nice to see so many of you who are going to lead palliative care or at least practice with palliative care in your minds. It's very, very heartening. Bye and thanks.
Thank you,
Bye,
thank
Sri
you.
Devi. Thank you so much.
Thank you so
Thank
much.
you.
Bye.
Thank you, Sridev ma'am, for facilitating. Thank you all for joining. Thank you. Let's see you in the next session. Bye.